Kia ora koutou and welcome to tonight's Goodfellow webinar, supported by an educational grant from GSK. We will be discussing the latest treatments and practical tips for asthma. My name is Pulasti and I'll be your facilitator for this webinar. I have the pleasure of introducing our speaker for tonight, Dr. Angela Moran. Angela is a respiratory and general physician in Christchurch. She has done clinical research fellowship at the University of Oxford, working in the severe asthma service at the John Radcliffe and Churchill Hospitals in Oxford. She also has subspecialist expertise in airways disease, particularly asthma, COPD, and chronic cough. And I'll pass on to Angela. Thank you, Angela.
Thank you very much for the kind introduction. It's my pleasure to be here with you to give you an update on asthma, the latest treatments, and some practical tips. These are my disclosures. These are the learning objectives for today to review the New Zealand asthma guidelines, to understand the difference between difficult to treat and severe asthma, to understand the different types of asthma, to understand the importance of treatable traits and using a multidimensional systematic review, to review the role of add-on therapies and biologic therapies for severe asthma, and to determine when patients with asthma should be referred to respiratory services for further assessment. We know that patients with severe asthma really struggle with a heavy burden of symptoms, exacerbations, and medication side effects. And here we have some data from the Severe Asthma web-based database from a registry from Australia, New Zealand, and Singapore, showing us that patients with severe asthma had a median number of maintenance respiratory medications of 4, compared with 2 patients with non-severe asthma, 2 as a median number of oral corticosteroid courses compared with 0 for non-severe asthma. 24% had visited an emergency department due to exacerbations compared with nearly 4% for those with non-severe asthma. And about 22% had been hospitalized for an exacerbation compared with just 2% for non-severe asthma. We know also from some data from the HealthStat database back from 2011 to 2012 that specifically looking at severe eosinophilic asthma in New Zealand, compared with other patients with asthma, those with severe eosinophilic asthma had over 1.5 times as many respiratory treatment prescriptions and higher all-cause healthcare resource utilization and total healthcare costs. And the asthma-related healthcare costs were 3.6 times greater for this group of patients. We know that oral corticosteroids have a lot of side effects affecting all different systems of the body, but patients can often be surprised by how many different side effects are possible and what these risks actually could look like for them. They're often more aware of things like skin tears and bruising than they are of higher risk of diabetes, cardiovascular disease, cerebrovascular disease, and indeed the risk of fractures and osteoporosis. So it's really important that we practice good oral corticosteroid stewardship and really consider every course of steroids and whether it is indeed necessary and will be helpful for our specific patient. This study shows us that even the lowest dose of oral corticosteroids was associated with significantly higher risk of adverse events in patients with asthma compared with those who weren't exposed. And importantly, that 5 courses of 5 days of 40 milligrams of prednisone a day is equivalent to a gram of prednisone. So quite a high cumulative dose that we don't necessarily calculate when we go to give the next course of prednisone. And it shows us that the risk for different adverse events is different, that the risk is highest for osteoporosis and fracture, even at these what are thought to be lower cumulative doses of prednisone. Looking at the New Zealand asthma guidelines from 2020, which were revised this year, we have on the left-hand side the anti-inflammatory reliever therapy-based algorithm using budesonide and formoterol, and on the right-hand side, the more traditional maintenance inhaled corticosteroid with short-acting beta agonist as reliever. Now, nothing has changed with these algorithms over the last 5 years. The treatments for mild and moderate asthma are still the same. And indeed, the treatments for worse asthma at step 3 are much the same, but we will look at beyond step 3 as we go forward. I think the most important line is the line beneath these algorithms that says, before stepping up, review inhaler technique, inhaler adherence, and treatable traits. Because increasing the dose of asthma treatment is of no use if the patient is not receiving this effectively for whatever reason, be it intentional or unintentional. Here we have the Assess, Adjust, Review cycle from GINA, the Global Initiative for Asthma. And it's a really important cycle that is really ongoing throughout an asthmatic's life. In the assess portion, we have confirming the diagnosis of asthma, which is really the most important thing. Then looking at symptom control, modifiable risk factors, comorbidities, inhaler technique and adherence, and the patient's goals, which are often not the same as our goals. Then adjusting treatment, pharmacological and non-pharmacological, and then reviewing the response a few months later each time. Again, reviewing symptoms, exacerbations, side effects of treatment, lung function, and patient satisfaction, and continuing this cycle. What is severe asthma? Well, true severe asthma only accounts for about 5% of all asthma, and it's defined by the AGACRS task force as asthma, which requires treatment with high-dose inhaled corticosteroids plus a second controller, which is often a long-acting beta agonist, and or systemic corticosteroids to prevent it from becoming uncontrolled, or which remains uncontrolled despite this therapy. So what's difficult to treat asthma then? Difficult to treat asthma looks a lot like severe asthma, but it responds to improving inhaler adherence, improving inhaler technique, optimizing asthma treatment, and addressing other key treatable traits, including asthma mimics such as dysfunctional breathing and inducible laryngeal obstruction. What proportion of asthma is severe or difficult to treat? Well, this is some data from a Dutch study, which is also published in GINA, showing that 24% of asthmatics were on step 4 to 5 treatment, so high-dose treatment, and that 17% had difficult to treat asthma, and nearly 4% had true severe asthma. It's important to look for some key warning signs, and these might be having 2 or more exacerbations in the last 12 months, or 2 or more courses of oral corticosteroids for asthma in the last 12 months, as these are not always the same number. Frequent reliever inhaler refills, which we saw more when patients were taking lots of SABA, and it's not quite so easy now with anti-inflammatory reliever therapy, but still an important thing to watch for, and any ED visits or hospitalizations. We know that most patients with severe asthma actually have what we call type 2 inflammation, which is predominantly driven by eosinophils. On the right-hand side is a depiction of the airway epithelium in red, and above this the airway lumen, with allergens on the left-hand side and irritants and pathogens on the right-hand side. Flowing down below the allergens on the left-hand side, we have the mast cell, degranulating and releasing histamines, prostaglandin, leukotrienes, with the B cells beneath this. And to the right, the mast cell, the dendritic cell, is an antigen-presenting cell, and beneath this a T helper 2 cell, which is releasing key cytokines, IL-4, IL-5, and IL-13. To the right of the T helper 2 cell, just above those blue smooth muscle cells, is the eosinophil, which importantly has a receptor for IL-5 on its surface. We'll talk about the importance of this and the newer treatments as we move forward. On the right-hand side, just below the airway epithelium, is a light grey triangle showing what we call alarmins, IL-33, IL-25, and TSLP, thymic stromal lymphopoietin. And these are some of the newer targets for treatments as upstream in the cascade of inflammation. Eosinophilic, or T2 high asthma as we call it, is really important because actually most of asthma is eosinophilic, up to 80%. It's just that it's not always looked for. And the key biomarkers of eosinophilic airway inflammation are blood eosinophils and FeNO, or exhaled nitric oxide. It's really important to note that blood eosinophil levels will not show up as abnormal. They won't flag unless they're markedly elevated above the reference range. And you're looking at a level of around 0.5 for this to occur. But actually in airways disease, a level of 0.3 is considered high, and even 0.15 to 0.3 may be of significance. So it's really important to actually read the numbers themselves in an asthmatic. It's also important to think about the context in which the blood test was taken, because just a single prednisone 40 milligram dose will lower blood eosinophils very close to zero just 4 to 6 hours later. So if the patient had already commenced a course of prednisone at home, or had a dose in the ambulance, and then had a blood test taken at the hospital, for example, then their eosinophils may be zero or close to this. So the context is important. Patients with eosinophilic asthma are higher risk for morbidity and mortality, but this is actually the most treatable type of asthma. So it's really important to determine if it's present. And these patients, if hospitalized, actually usually have the lowest length of stay. Now, I've mentioned the term treatable traits. What are these? A lot of work was done globally looking at this concept and looking at what traits, when you treat them, improve asthma. And they were divided into these 3 different domains. In the pulmonary domain, we have airflow limitation that you measure on spirometry, eosinophilic airway inflammation, which we've been talking about and we'll talk more about, neutrophilic airway inflammation, which often goes hand in hand with the next 2, frequent chest infections and pathogen colonization, mucus hypersecretion, which we see with both eosinophilic and neutrophilic airway inflammation, oxygen desaturation, breathlessness, and systemic allergy. In the extrapulmonary domain, importantly, we have dysfunctional breathing, which we see really commonly both together with asthma and without asthma, but mimicking asthma. So many patients who have an incorrect diagnosis of asthma actually have an abnormal breathing pattern. And we also see a lot of this after viral infections, for example, and so a lot of this after COVID-19 infections. So it's really important when examining your patients to actually observe their breathing pattern and to consider what history they're giving you. Often patients tell you that they really struggle to take a deep breath in. They can't seem to get enough air. These are common descriptions. And patients don't necessarily hyperventilate. That's only one abnormal breathing pattern. Patients may have very different breathing patterns. They might have slow sighing respirations instead. One of the possible ways of screening for dysfunctional breathing is to use the Nijmegen questionnaire, which is easily found online. And these patients should be referred to a respiratory physiotherapist for assessment and intervention. Other extrapulmonary treatable traits: anemia, systemic inflammation, daytime sleepiness and obesity. Depression and anxiety are extremely important. It's been shown more recently that patients who have mental health problems actually, unfortunately, do not do as well, even with the best treatments for asthma, if these are not addressed. So it's really, really important to address these as best possible. Any other significant medical problems and cardiac problems impact. And last but not least in this column, vocal cord dysfunction, also known as inducible laryngeal obstruction. Like dysfunctional breathing, this can be an asthma mimic, but it also commonly coexists with asthma. So it's important, again, to ask some key questions like, where does your patient feel their symptoms? Do they get any throat tightness? Are there any specific triggers, particularly things like strong-smelling perfumes, car fumes, deodorants, cleaning products? Other things like cold air and exercise are common triggers. But they can also trigger asthma, so it's important to try and tease it apart. If anybody observes an episode, it may look like an asthma attack, but something that is different is that there is stridor present. So that's an important distinguishing factor. And these patients should see a speech language therapist and sometimes an ENT specialist also. Under risk factors and behavioural traits, we have the absence of a written action plan, poor exercise tolerance, low bone density and muscle mass, smoking, inhaler device polypharmacy, poor inhaler technique, and poor adherence. So what are the options in New Zealand when we're looking at patients who have uncontrolled asthma despite being at step 3? Well, that depends on what type of asthma they have. If they have allergic asthma, they may need courses of prednisone, but ultimately they may qualify for funded anti-IgE omalizumab on special authority. If they have eosinophilic asthma with key features of high blood eosinophils and FeNO, then again they may require courses of prednisone. that again may qualify ultimately for biologic therapy to be funded on special authority. And we'll talk about the anti-IL-5 treatments a bit more as we go on. If they have the absence of high eosinophils, what we would actually call T2 low asthma, or non-eosinophilic asthma, then the options are a little different, and we need to really see what's the root problem here. If they have significant airflow limitation, then they may benefit from a llama inhaler being added. This is not funded in New Zealand specifically for asthma, but if they also have COPD, then it's certainly a good option. Or patients may wish to self-fund this and often find this very beneficial. Theophylline is being used less and less now, but you may still see an occasional patient on this. Montelukast is not a targeted treatment, but I'm seeing more and more patients being commenced on this in primary care. And it's just important to be careful that they don't have a contraindication and check their mental health history carefully with this and try and work out which patients may be most likely to benefit from this. And usually these patients who have allergy or patients who have exercise-induced asthma. Azithromycin is a good option for both T2 high and T2 low asthma, particularly where there's underlying chronic airway infection. Again, this is not funded in New Zealand specifically for asthma, but many patients are happy to self-fund this, as we usually only give it for a few months over the winter each year if we think this will be helpful, and it's non-particularly costly. So it is an option that you may see patients commenced on if they attend respiratory clinic. Here we have some data from the prospective Arietta study showing you the importance of the biomarkers blood eosinophils and FeNO. On the y-axis, we have exacerbation rate per patient year, and on the x-axis, we have FeNO. The dark blue column denotes patients who had the highest blood eosinophils, so 0.3 times 10 to the 9 per litre or more, and the light blue are less than 0.3 times 10 to the 9 per litre. So here you can see that the patients that are highest risk for exacerbations are those with high blood eosinophils and high FeNO. The next highest risk is high blood eosinophils and low FeNO. And next is high FeNO and low blood eosinophils. So you can see that both of these are important, but that blood eosinophils actually are more additive to the risk. So you can think about blood eosinophils and FeNO as being like the blood pressure and cholesterol of the airways. They're really important for working out risk of asthma attack. So very important that we look at patients who have high biomarkers and manage this accordingly. Here we have some data from the mepolizumab studies, the DREAM and MENSA studies, a post-hoc analysis, showing you again on the y-axis the exacerbation rate per year, and on the x-axis here, we're grouped by blood eosinophil count. So the furthest right is the highest blood eosinophil level at 0.5 times 10 to the 9 per litre or more. And the red column is those who've had mepolizumab, and grey is placebo. So you can see that at the highest blood eosinophil group, that there's a 70% reduction in exacerbations for those treated with mepolizumab compared with placebo. This is a huge reduction in exacerbations in this group. Now, the next group down, with blood eosinophils of 0.3 to 0.5, had a 36% reduction in exacerbations. And even the next group down, you recall I mentioned that blood eosinophils of 0.15 to 0.3 can be significant. Well, this is the group we see with a 33% reduction in exacerbations, which is not insignificant. But the group in New Zealand who are currently receiving funded treatment on special authority is the top end here. We have to have blood eosinophils over 0.5 in New Zealand, unfortunately, at the moment to qualify. And we're working on bringing this down in line with international standards. So what biologic therapies do we have available for severe asthma in New Zealand? We have the anti-IgE omalizumab, which has been around for many years, the anti-IL-5 mepolizumab, and the anti-IL-5 receptor benralizumab, and the latter two being for severe eosinophilic asthma. So mepolizumab is a humanized monoclonal antibody against IL-5. And IL-5 is a really important cytokine because it promotes eosinophil proliferation, maturation, and differentiation. Mepolizumab comes in this pre-filled pen, which is disposable, and patients receive it as a subcut injection every 4 weeks. And what we do locally in Christchurch is we get patients to come into the hospital medical day unit for their first 2 doses, for these to be supervised and for them to learn how to do this and make sure they don't have any reactions, which are exceedingly rare. And then patients are able to continue self-administering this at home afterwards, which makes it an extremely convenient treatment. It's important to remember that this is an add-on treatment to high-dose inhaled therapy. Over time, we may decrease their inhaled corticosteroid dose if they're doing very well, but this is something that needs to be done by the physician supervising their biologic therapy. So it's really important to not decrease their inhalers or stop them when they're put on biologic therapy. And sometimes patients feel so much better that they're really, really keen to stop. Here are just some data from the phase 3 Mensa study of mepolizumab showing you the primary endpoint exacerbation reduction. And for those who receive subcut mepolizumab in the bright orange column, you can see a 53% reduction in exacerbations compared with placebo in the grey column. And here's some data from the Reality A study, which was a real-world study of mepolizumab, where physicians were allowed to choose patients they thought would benefit from mepolizumab to register them. They just needed to have 12 months of data prior to commencing. And on the left-hand side, you can see that for the rate of clinically significant exacerbations, there was a 69% reduction 12 months post-exposure compared with the 12-month pre-exposure data. And on the right-hand graph, you can see the rate of exacerbations requiring ED visits or hospitalizations. There was a 77% reduction 12 months post-exposure to mepolizumab compared with the 12 months pre-exposure. So even a greater benefit in the real-world study than what was seen in the phase 3 trials. There's some data from the Sirius study, which was a study looking at patients on maintenance prednisone for their severe eosinophilic asthma. And this was continued through the open-label safety extension studies COSMOS and COSMEX here, giving us data out to 4.8 years. You can see the number of weeks along the x-axis. And on the y-axis, we have the median oral corticosteroid dose. And they start with an optimized dose at the beginning. And you can see that this decreases significantly throughout these 3 studies. And by the end of it, the patients are on an extremely low dose of prednisone. And in fact, that 45% for which we had continuous data had actually managed to cut them off their maintenance prednisone completely on mepolizumab. Here are just some of the safety data from the Reality A study, showing you that actually the adverse events related to mepolizumab were quite low. The things that we tend to see more commonly, if anything, are injection site reactions, headaches, flu-like symptoms, occasionally some abdominal pain. But it's exceedingly rare for patients to actually need to discontinue the medicine as a result of any of these, and often they decrease in severity over time. Now, benralizumab is a humanized monoclonal antibody against the IL-5 receptor, so is often used relatively interchangeably with mepolizumab, but there are some nuanced differences which can be worked out by a physician who manages severe asthma regularly. It also comes in a pre-filled subcut pen, just a slightly different color, and it's given every 4 weeks for the first 3 doses, but then spaces out to every 8 weeks after that. Like mepolizumab, it decreases exacerbations of severe eosinophilic asthma and enables a safe withdrawal of maintenance oral corticosteroids. It works by a slightly different mechanism, antibody-dependent cell-mediated cytotoxicity. And the reason that that's important is it essentially causes apoptosis of eosinophils. So if you look at a full blood count of a patient on benralizumab, you might spot that their eosinophils are 0 or very close to. And a lot of work was done looking at whether this was a problem, and no particular issues were observed with depleting eosinophils that far. Here is again some phase 3 trial data for benralizumab, the Sirocco and Kalima studies. There was a 51% reduction in exacerbations in the Sirocco study and a 28% reduction in the Kalima study. Not quite as good, but there were some differences in geographical region and the patients who were recruited with them not having as severe asthma as in the Sirocco study. And the Bora open-label safety extension study shows at year 2 that there was a further reduction in exacerbations. The Zonda study on benralizumab was like a serious study of mepolizumab, looking at patients who were on maintenance oral corticosteroids for their severe eosinophilic asthma. And you can see in the blue column that patients on benralizumab had a 75% reduction in median daily oral corticosteroid dose, compared with 25% on placebo. And 52% of patients on benralizumab were able to completely stop their maintenance prednisone. Some safety data for benralizumab. Again, adverse events are extremely low. Commonly reported ones are nasopharyngitis, worsening asthma, and upper respiratory tract symptoms. And only about 2% of patients had to discontinue treatment because of an adverse event. There weren't any reports of helminth parasitic infections, and the rates of serious infections and newly diagnosed malignancies are low. And so that's relating back to what I was saying about depleting blood eosinophils that far when they have been known to have a homeostatic effect in the body. And so this has not been shown to be a specific problem. So I thought I'd discuss a little bit about what we know about exacerbations in patients on anti-IL-5 biologics, because patients present to primary care when they exacerbate, and these are a unique group of patients. So the MEX study was done patients on mepolizumab for their severe eosinophilic asthma, and it was carried out at 4 UK specialist severe asthma centres. There were unscheduled exacerbation assessments for these patients when their symptoms worsened. And they found really that these patients fell into 2 distinct groups, which were largely differentiated by their FeNO levels. Now, this is not quite so helpful in primary care where FeNO can be difficult to access, but I think the principle is important. They were essentially a group of patients who had low FeNO and high CRP and were thought to be having infective events, and patients who were thought to be having an eosinophilic exacerbation. So they tended to be one or the other, and therefore this challenges routinely using prednisone for every patient presenting with an exacerbation on mepolizumab. So I tend to give quite pragmatic advice around this to those working in primary care. And I would really strongly urge you, if a patient presents with an exacerbation, to look for any symptoms or signs of infection or a high CRP. And if this is present, to give them a course of antibiotics. But if not, if there's absolutely no sign of infection, then they may need a short course of prednisone. So it's important to not routinely give both of these together. It's really important to try and decrease the number of courses of prednisone, because this is our main aim, to try and decrease exposure to oral corticosteroids and their adverse effects. But also, if the patient is getting good benefit from the biologic therapy, if they have too many courses of prednisone, they will not be able to continue on it after the 12-month assessment mark. So it's therefore important to share with you what we need to complete to renew biologics on special authority, which is that their symptoms need to have improved, but they also need to have at least halved their exacerbations. So halved the number of courses of prednisone they're having, or if they're on maintenance prednisone, halved the maintenance prednisone dose. That means if they only had 4 courses of prednisone in the previous 12 months, which is the lowest number to access anti-IL-5 biologic therapy, that they cannot have more than 2 courses in the next 12 months before they're assessed for renewal. Now, with respect to benralizumab, we've more recently had the BenRex study done, which was done at 15 UK centres. And just like the MEX study, there were unscheduled exacerbation assessments. And they found something similar. They found that about 2/3 of exacerbations were secondary to infection, and about 1/3 were likely due to a bit of residual eosinophilic airway inflammation. So again, raises the same questions and challenges using prednisone when there's an infection. So now coming to some practical questions which patients usually ask before they're commenced on biologic therapy. And I've brought 3 of these to you. The first one is, how long do I need to stay on this injection if I start it? Well, currently the evidence shows that the anti-IL-5 biologics, if they're working well, need to be continued indefinitely. We have this information from the COMET study of mepolizumab, which was done some time ago, showing us that patients who were switched to placebo, you can see in the orange column here at week 12, had their blood eosinophil count shoot back up again, and also had increased asthma worsenings compared with those who were continued on mepolizumab. And this difference was maintained from week 12 through to week 52. So this is where our information comes from. And until anything changes, we get any newer biologics that have any other studies with new information, this is what we're basing this on. It's very important. This is different from omalizumab, notably, where sometimes a drug holiday is possible. The second question is, what if I want to travel? And I'm asked this really frequently. So if patients are about to take a short trip, I ask them to see if they can possibly plan it around their injection timing. If they want to take a longer trip, well, obviously more than 3 months is going to be problematic. But if it's sometime under 3 months, then it's advisable that they carry their injections with them in the plane cabin in a cooler bag. And I usually give them a letter to carry with them because it does contain a small needle. They should put it in the fridge again as soon as possible. I have had a patient who wanted to go on a big road trip to the US, and that was not something that was going to be feasible because it wasn't going to be possible to keep their injections at an optimal temperature to maintain the stability of the medicine. So it is an important consideration. The third question, even if it's not asked, is something that we need to consider. And it's what if I want to become pregnant, but what if I need to consider the effect that a biologic therapy might have? So we have patients who are unwell with their asthma during pregnancy, and we need to consider whether starting a biologic is the right thing to do, which can be a tricky decision. We have patients who are young. We have teenagers who are not even contemplating this question, whom we need to consider it on their behalf in advance. So it's very important to think about the key question, which is asthma control, and that maintaining asthma control during pregnancy is the most important thing in relaying this to patients and others who may be important in this decision also. Because, of course, poor asthma control is associated with a number of adverse outcomes in pregnancy. Now, the biologics are IgG subclasses, so they're actively transported across the placenta in the 3rd trimester, but only crossed by passive diffusion in early pregnancy. There is preferential transfer of IgG3 and IgG4 in breast milk, but the anti-IL-5s are IgG1. They have large molecular size and they are degraded, so it's thought that they're unlikely to have much effect. But what we really need is registry information, and there are ongoing registries, but we don't have data from these as yet. So it's important that we're transparent with patients about this information. I think a really helpful paper was the International Consensus on the Use of Asthma Biologics in Pregnancy that was published this year. And this was a Delphi study, which involved surveying 141 panelists from 32 countries, of which I was one. And it was a very good study with 2 rounds. So based on the answers to the first round of questions, there were modifications in a second round put out. And just to show you the consensus information from this, the consensus was that asthma biologics do not need to be stopped while patients are trying to conceive, that they can be used throughout pregnancy, that they can be initiated during pregnancy, that asthma admissions to hospital or ICU admissions or presence of steroid side effects might lower the threshold for us initiating a biologic during pregnancy, that asthma biologics can be initiated and continued whilst breastfeeding, and that, very importantly, shared decision-making should underpin all decisions regarding biologic use during conception, pregnancy, and breastfeeding. Another important difference from some other biologics is that there isn't a recommendation to stop biologics before the 3rd trimester, providing it's helping to maintain asthma stability, as these T2 biologics are not broadly immunosuppressive. as some of the rheumatological ones are. Now, some practical tips for asthma reviews and referrals. I'm often asked how to review asthma quickly in primary care, and I know that you don't always even have the 10 minutes that I've cited here. But I think the most important thing is to get the documentation right so you have to do less each time. And the first one that's probably the most time consuming is to check the diagnosis is correct. Has the patient had documented spirometry showing variable airflow limitation? Have they had a peak flow diary done showing this? Did they have a bronchial challenge test done at some stage? Is there some objective evidence of diagnosis? Or if it hasn't been confirmed, document that also, because it will save you time or your colleagues time next time somebody goes to do an asthma review. Assess asthma control using the asthma control test if possible. This is an objective validated tool. There are others, but this one is the one that's used most commonly in Australasia, and it's the one that we have to use to access biologic therapies in New Zealand. If you are not familiar with it, it's just 5 questions, and it asks about asthma control in the preceding 4 weeks. And it's easily found at www.asthmacontroltest.com, and even patients can access this. If patients are not familiar with this, I would coach them at the beginning to make sure that they're actually considering what normal looks like. If they've had asthma all their lives, they may not know what a normal life looks like. So really make sure that they're not underscoring themselves. And sometimes I say to them, just think about somebody you know who doesn't have asthma about your age and what they're able to do, and maybe compare yourself to them a little bit to work out how normal this is. And this might help them to complete the questionnaire better. Ask them about their inhaler adherence. I always ask my patients when I see them, what are you taking for your asthma at the moment? It's not that I've forgotten what I prescribed for them or that I don't know them particularly well, as I often do. Sometimes patients think that I've forgotten and saying, you prescribed this for me last time, in which case I stop them and say, but what are you taking at the moment? It gives them an opening. It gives them an option to tell you is they're taking something different from what was prescribed previously. And it's a way to open the conversation non-judgmentally to find out if there is a reason, if they're taking something different, why that is. Is it intentional? And if so, working out what their beliefs are and whether they need any further education. I think it's really important to get the message across, even to patients who are really unsure about treatment for asthma, that inhaled corticosteroids decrease airway inflammation, and that inflammation that goes unchecked causes airway damage and can cause irreversible symptoms in time. So I think just breaking it down to make sure that patients understand that to help them if adherence is a problem due to not thinking that they need to take the treatment. Check their dispensing record, look for the number of courses of prednisone in the last 12 months, review their previous blood eosinophil counts. I always go back at least a couple of years and have a look if you refer a patient in, and usually I go back further than that. And again, remember the context in which the blood test was taken, or try and work it out based on when they may have presented with an exacerbation, whether they may have already had steroids at that time. Record their highest blood eosinophil count so you can refer to this later. Identify and manage any asthma mimics and treatable traits. Don't forget about their breathing pattern or looking for evidence of vocal cord issues. Assess their inhaler technique or get somebody else in the practice to do it if you don't have time. It's really important that this is done at least once a year, but hopefully each time they present, because this can certainly lapse in between visits to a suboptimal technique. Optimize their asthma treatment. Check that they have a written asthma plan done and decide if they need referring to see a respiratory specialist. So I've just included here the appendix from the New Zealand Adult Asthma Guidelines, and this is the 4-step asthma consultation proposed. And step 1 is assess asthma control using the asthma control test I just mentioned, and thinking about histories of severe asthma attacks and number of courses of prednisone. Step 2, considering other relevant clinical issues, so really looking at treatable traits. Step 3, decide if an increase or decrease in maintenance treatment is required. And step 4, completing the asthma action plan. Which patients should be referred for specialist review? Well, any patient with asthma whom you are concerned about. patients in whom there's a difficulty in making the diagnosis. It can be complex. Any patient with asthma who's had more than 2 courses of prednisone in the last 12 months, despite optimal inhaled therapy. That's really key that this has been optimized, that they are taking it and they're taking it correctly. Patients with difficult or severe asthma, patients with eosinophilic asthma reaching the threshold for treatment with a biologic. So for us, that is that they need to be an adherent to high-dose inhaled therapy for at least the last few months. They need to have had 4 or more courses of prednisone in the last 12 months, and they need an asthma control test score of 10 or less, which is very symptomatic. But we're certainly happy to see patients before they reach this mark because often there's much that can be done preparing for this. Why refer? Well, we can review the diagnosis. We can help in differentiating difficult to treat from severe asthma. We can do phenotyping and provide biomarker-directed therapy with access to biologic treatments. So what should be included in the referral? Well, to get the best response to your referral, I strongly urge you to please not send a referral that says, please see the consult notes below. It can take so long to sift through all the consultation notes that often what you're really wanting to convey is lost. Even 4 or 5 short lines that don't need to be full sentences that say what the concern is, that document whether the patient has confirmed asthma, so whether there is spirometry showing this or whether it's done by a peak flow diary, whether it's just a clinical diagnosis that needs confirmation, whether there's concern that the diagnosis is incorrect, is all helpful. Their highest blood eosinophil count and date is extremely helpful. If in the high volume of referrals received, somebody doesn't look at the eosinophil count, your referral may not receive the priority it needs. Confirmation that you have checked their inhaler adherence and technique. We spend a lot of time doing this in clinics, and this could be used in other ways. Number of exacerbations, courses of steroids in the past 12 months is helpful to prioritize, and their current asthma treatment, as well as their ACT score if you've done it. And if you've identified any treatable traits, that's also helpful, but a little more the icing on the cake. The skills for your next clinic. Discuss treatment adherence with all your patients with asthma. Even that brief question that I use with each patient may help you to not just increase their treatment where they may not be getting it effectively. Ensure all patients with asthma have their inhaler technique checked regularly. Review historic asthma diagnoses, particularly where a patient is not responding to asthma treatment, as it may well be an incorrect diagnosis. Look for key treatable traits and check blood eosinophil levels in anybody who has suboptimal asthma control. It's really, really important to know what you're treating, because a patient who doesn't have high blood eosinophil levels is unlikely to have much response to prednisone and will simply gain more and more side effects. So thank you very much for your attention and interest, and I look forward to your questions in our Q&A going forward.
Wonderful. Thank you so much, Angela. I'll move on to just some of the questions that have come through since the presentation. I think it would be helpful for the audience if we do a bit more of a review of the funding of the biologics. So my understanding, correct me if I'm wrong, omalizumab, there is special authority funding for that. Could you talk to the audience a bit more about the criteria? You kind of alluded to, the minimum of 4 courses of steroids. People would like to know about age as well and those kind of cutoffs. Yeah.
So omalizumab's a little bit different quite a bit different from the anti-IL-5 therapies. And sometimes it's seen as a little bit easier to access because we don't have to worry about the blood eosinophil threshold. There it relates to the IgE level. And sometimes a barrier there for patients, if you're wondering in terms of why a patient might not get put on omalizumab, is that their IgE level is often too high. So there is a range, and I think maximum is 1,300. And we see many patients with IgEs higher than this. So that can be a reason why a patient's not put on omalizumab, even though they're needing frequent courses of steroids and their asthma looks severe. They just might not fit into that group. Omalizumab also only has special authority for 6 months and then needs review, so that's different also. But with the anti-IL-5s, mepolizumab and benralizumab, the special authorities are very similar for the 2 of those. And so these patients need to be on high-dose inhaled steroids, so they must be adherent to their treatment is the first thing. They don't need to be on any other additional treatments, but we must have addressed any other asthma mimics like dysfunctional breathing and inducible laryngeal obstruction. So we have to have dealt with those. We don't necessarily have to have fully treated those. The wording is a little difficult on special throat, but we must have at least addressed them and them beginning some treatment, because this can be quite an ongoing thing, as you'll know, for patients with breathing pattern disorders. They need to have had 4 or more courses of prednisone in the preceding 12 months. And it's okay if they haven't had that many at the time that you refer them, because usually what happens is I see a patient and their asthma control is poor, and I often give them a course of prednisone when I see them, and then give them another one for the next time their asthma flares. Or it may be that the patient hasn't had many courses of prednisone because they don't feel like they get asthma exacerbations. It's just that their asthma worsens and their asthma is actually really poorly controlled a lot of the time. So it may be that it's quite quick and easy to get through a few courses of prednisone because they get better really quickly. And typically these patients start to improve within 24 to 48 hours, which is a good way to predict who's going to respond to one of these biologics. And then they often, unfortunately, bounce back down to their usual after 2 or 3 weeks. It doesn't usually take very long for things to deteriorate again for patients with quite bad asthma. So we can actually end up getting through the courses of prednisone side at special authority quite quickly. So don't necessarily wait until they've had 4 courses. So that side I'd be quite loose about on the referral. What's really difficult for us is getting the blood eosinophil count right. So if you've already got a patient who's got a high blood eosinophil count over 0.5, then you've already got the hardest part right for us. And if they've got poor asthma control and they're going to score badly on symptom control and the asthma control test score, then they're likely to qualify. So get those patients referred in. If they haven't got a high blood eosinophil count, then that's something that we then need to start trying to prove. So the most helpful thing you can do while you're waiting anything between 3 and 6 months for your patient to be seen is to start getting some full blood counts taken. I always give patients a bunch of blood test forms and say, get this done when your asthma is getting bad, when you feel like you're about to need some prednisone, before you take the prednisone tablet. When the asthma is worst, it's when the eosinophils will be highest on the blood test. So if you can get some eosinophil levels done while your patient is waiting, if you think that's the way they're headed, that will be extremely helpful. Otherwise, we're simply going to have to send them away with the blood test forms and say, we'll see you again in 3 or 4 months and see how things are looking. But if we spot a blood test in the meantime that qualifies, we'll get in touch with you. That's usually what I do. I end up ringing patients once I see a blood test count that ends up qualifying at that point, get them straight onto the biologic at that time. So we've only got a 12-month window for the blood eosinophil count. So if it's historical, if it was 2 years ago, then unfortunately that's no good to us. Or if it's really close to the 12-month mark, and unfortunately by the time they get into clinic, it might be another few months and it will have expired, get some more taken, because it would be a tragedy if that eosinophil count's expired and we can't use it. Some patients are really, really keen. Their asthma's so bad that they really want to prove this, that they get regular blood tests done. I have patients who get weekly blood tests done. Some get fortnightly blood tests done. And this is indeed very helpful, but of course is a bit of a burden in terms of getting it done and cost. And I wouldn't advocate that for everybody, but if they've got really, really severe asthma, then that can be what we need to do to try and prove this. So those are the main things. And those are things that can be helpful to do in primary care in the lead up to them being seen to get them onto biologic therapy.
Right. And so just to answer a couple of follow-up questions following on from your response. So just to clarify for everyone, the cutoff for the eosinophil count is greater than 0.5.
Correct.
Yeah, correct. Yeah. There was also Yes. There was also someone who asked a question a little while back saying patients who are having greater than 0.5 eosinophil count, but not on maximum dose of inhaled therapy, are they still eligible for biological therapies? I think from your response, not no,
No.
because they need to be optimized ideally in primary care before they really.
Exactly. Yeah. And if they're not, then again, we end up seeing these patients and maximizing their inhaled steroids and saying, see you in 3 months. And again, it's a bit of a waste of a clinic slot, really.
Mm.
So please do that first.
Sure. Could you just confirm the age range as well? I think I saw for omalizumab, it's from 6 years onwards. Yeah,
And for the anti-IL-5s, 12.
12. Yeah. So it is available. I have one person asking about, is it available for children? So it can be used in
Yeah,
female.
so the pediatrics department do use the biologics. Obviously, the numbers are much lower, and they tend to use it on more complex cases and often discuss these with me. But it is certainly something that would be available if you refer through to pediatric respiratory.
Great. Yeah. Someone's asked, is it possible to self-fund for biologics?
That's a tricky question. And I think so far the answer is um, I'm not aware of anybody doing this in New Zealand. They are very costly, and it's not an avenue that anybody has taken so far.
Sure. Are you aware of, I mean, some of our patients have private health insurance.
I also work in the private sector, and Southern Cross were not keen to fund it since it was available on special authority through Pharmac.
Interesting.
So, yeah.
Yeah. One person that was also asked querying about the timing of checking the eosinophil count in relation to prednisone doses. Is there anything we need to take in consideration for that if someone's been on a course and help?
Yeah, so everybody's a little bit different about when their eosinophils start to peak again, but typically the best guide is when they're becoming symptomatic. If they have no symptoms, it's not a good time to check their eosinophils. Usually, I'd wait a couple of weeks if possible as a minimum after a course of prednisone, but the best time to take it is when the patient is most symptomatic.
Fair enough. You also talked about the asthma control test. Who there's a question asking, are nurses able to do it or other members of the primary care team, or is it more of a GP related test?
Often patients can do it themselves. And I often get patients to do that. They can access the website themselves. It's really easy to do. Absolutely anybody can do this. Certainly, my clinical nurse specialist does this with all patients before seeing me for severe asthma clinic. And it's really easy to do.
And certainly, participants can look it up online. Do you mind just giving us a brief summary of the kind of broad headings? What kind of questions are asked? What kind of over what time period patients need to relay their symptoms?
Yeah. So it looks at symptoms over the previous 4 weeks. It asks patients whether they've got activity limitation with their asthma. It asks them whether they've got nocturnal symptoms, waking earlier than usual. It asks them about their reliever inhaler use. And often that's the bit you need to clarify if they're on a maintenance and reliever therapy regime. They're not sure what constitutes their reliever. That might be something you need to advise them on if they were going to do it themselves. And it asks them about their perception of their control, which is also another very subjective part. And again, it's really important for patients to realize that they need to compare themselves to what they really should be to get this right. Yeah, we don't want them to have a score that's 1 point different based on their subjective experience being that their asthma is not too bad, but in fact, they've had 8 courses of prednisone in the year and frequently in and out seeing you. So, yeah.
I also had a question regarding ruling out any mimics. You were kind of talking in particular about disordered breathing, and I think it's something probably we in primary care vaguely are aware of, but probably don't really assess very much. You mentioned the Nijmegen questionnaire, which I've come across once or twice and fumbled my way through it with the patient. Do you mind talking to us a bit more about it? I think it's probably useful for us to be aware of that and be really
Yeah.
considering that. Yeah.
So it's just one of the possible screening questionnaires, and respiratory physiotherapists do use other ones, but it's one that commonly is put out for severe asthma clinics to use. And so I use it frequently with patients. And what I tend to do is I tend to print one off from online that often has a line underneath it that talks about the score and talks about hyperventilation syndrome. So I remove that and then have the questionnaire available for patients without having that line there, so it doesn't already have an immediate connotation to it, because of course we're talking about a lot more than just hyperventilation. And then it has a lot of random symptoms. And I say that to patients. We have a lot of different random symptoms that we're going to ask you about here. And we just ask them to tick how frequently they get any of these symptoms. And it ranges through all the things that one might experience, from breathlessness, chest pain, dizziness, palpitations, all the things, cold extremities, tingling extremities, um, feelings of tenseness, tightness around the mouth, lots of different things that may be seen with a breathing pattern disorder. And patients are really surprised to realize that actually many of the symptoms they describe are here on this piece of paper, and say, how did you know to ask me all of these questions? And then when they see a physiotherapist and learn how it all relates together, and how these symptoms are all produced just by their breathing pattern, they can be quite surprised. They're even more surprised if they find out that they have that instead of asthma and have no asthma. But they're always relieved if you can take away some medicines that they didn't need, and give them something that they can do themselves, that is not a medication, to actually overcome this. So it's a really easy questionnaire to use. But I also recommend strongly watching how your patient breathes as well, because you'll observe much that you didn't realize you were observing, while you were looking at them, and also while you were listening to their chests. And sometimes you'll just notice, that breath sounds are really quite absent when their spirometry looked really good. So what's the reason for the mismatch? And these things that you normally observe but don't necessarily put all together can actually make a really meaningful piece of the puzzle for them.
I was interested to hear you said it's been worse since COVID, disordered breathing. Yeah.
We saw a lot of it after COVID-19 infections, but it's certainly not the only virus to cause it. And I see it a lot with all sorts of infections. Patients present and they've been told that they have asthma after a single viral infection. They've been given an inhaler, or they've believe that they have asthma, even though they were perhaps given a Symbicort for a different reason. And it's continued since then. And then they want to know, what do I do from now that I have asthma? But in fact, a lot of this is breathing pattern disorder. We don't know exactly what causes breathing pattern disorders, but we do know that when something changes, like a viral trigger that alters their normal breathing, that it can stick. So the normal automated breathing pattern can somehow get knocked out of kilter and stay that way until they retrain it. But it just needs someone to identify it. Physios are so good at doing that, and then setting them on the right path for retraining, but encouraging them with this, because it's quite a long journey sometimes for retraining breathing patterns.
A few other questions moving on from disordered breathing. I could ask you so many more. One of the common side effects of inhaled steroids is hoarseness. It sometimes contributes to less adherence with inhalers. Any thoughts on that? Yeah, I know.
Hoarseness
Yeah, I
is
think.
a tricky one.
Mm.
And we certainly do see this a lot, and it affects patients to different degrees, and some patients tolerate it better than others. For some people, they just say, other people notice it when I speak, but it doesn't really bother me, in which case I don't worry about it too much. But where it's really upsetting a patient and there's no other obvious cause for the hoarseness, and it's thought to be due to that, then it depends on what inhaler device type they're using and what particular treatment they're on. If they're receiving a dry powdered inhaler, sometimes those are more irritant. So sometimes I might suggest trying a metered dose inhaler with a spacer to see if they get any difference with that. Or working out exactly what type of asthma they have. Do they need that much inhaled steroid? Can we back away from that but still give them enough bronchodilator? But often we still need to give them a reasonable dose of inhaled steroid, and it's trying to strike that balance and say, which is worse for you, the asthma control, the hoarseness? And patients themselves tend to find a spot where they're comfortable. Say, at this point, I can manage okay, I can talk on the phone, I can still manage to have conversations and do what I need to do. Yeah.
And on the topic of asthma inhalers, I guess getting back to the kind of eligibility criteria for the biologics, do you have to have tried multiple different inhalers to have fit the criteria for
No.
optimized treatment? No. Yeah.
No, you do not. And I think that's worth mentioning is often I see people who have been cycled through every color and brand of inhaler, but it's unclear what the rationale was. And it wouldn't worry me, except often it's a de-escalation in dose of inhaled steroids in there. And I think that's inadvertent, and people don't necessarily realize they might be going to a lower strength inhaler. So it's important to make sure that in changing between brands, unless there's a side effect like hoarseness and you're trying to decrease things, if you're trying to manage severe uncontrolled asthma that's not improving on the inhaler that they're on, you mustn't decrease the dose inadvertently. So work out what's comparable, make sure you're at least at the same, if not increasing. But for the vast majority of patients in New Zealand, and I say that because of what we have available funded here, the reality is that for patients with severe asthma, the best way to manage things is with a maintenance and reliever therapy regime, because it gives them the ability to increase their inhaled steroid when they're unwell. And so that therefore leaves the ball in their court, and they can back away a little bit when they're better, but on a bad day, they can really maximize out those 12 inhalations, and really make sure that they're getting the most inhaled steroid possible. Going and getting courses of prednisone when they're not maximizing their inhaled steroid is counterintuitive. If there's something you can do that's locally delivered rather than giving systemic side effects that does the job, then that would be better first off.
Are you aware of any situations where gastroesophageal reflux can contribute to someone's asthma?
Yes, gastroesophageal refluxes are one of the important traits that we look for, a common comorbidity that can certainly impact. And if it's uncontrolled, I would always optimize reflux treatment for any patient with asthma.
There's also a question someone's asked, can biologic treatments be used for hay fever as well? It might be useful just to talk briefly, and it's probably going to be our last question for tonight around atopy, in general, and the use of biological treatments.
Not specifically for hay fever on its own, but certainly where that's a significant comorbidity, then there is more of a case for using omalizumab in that instance. But usually these patients, if they've got really bad hay fever, will have seen an immunologist and may have likely tried immunotherapy and other treatments alongside.
And eczema, anything along, I guess, yeah, sticking to the topic of atopy.
Not funded in New Zealand currently.
Mhm.
There are newer treatments available elsewhere that we don't as yet have, and it's very much watch this space. Omalizumab is all we have funded for allergy in New Zealand, and we actually use it relatively infrequently for asthma. I think I only have 2 patients left on it now, because many patients actually, even though they have allergy, do really well on anti-IL-5s. So unless allergy is really their predominant trait, and they don't have much in the way of eosinophils, then we're more likely to go for an anti-IL-5 for them. And the reason is there is a difference in terms of withdrawing steroids. Omalizumab doesn't have the backing that the anti-IL-5s do in being able to reduce how much steroid patients get. For mepolizumab and benralizumab, we know that we can reduce steroid courses, and that's one of the key draw cards for them.
Fair enough. Right. Well, on that note, I think we'll wrap up for tonight. We've hit 8:45, so I'll finish by thanking Angela again. Thank you very much for an excellent presentation and for answering all your questions. Thank you to our attendees for your engagement and involvement, and we wish you a good night. Take care.